Good afternoon, ladies and gentlemen. Welcome to episode 45 of the Royal Society of Medicine series by health professionals for health professionals. And I'm delighted to say our guest today is Professor John Edmunds, who is the epidemiologist extraordinaire, the crown prince of modeling, and the man in the public eye. Now, John, at the start of 2020, you were already a highly experienced, highly cited academic, hundreds of publications, huge index, remarkable range of subjects that you've written on, even in just the last couple of years. But then something happened at the start of 2020. Your publications, citations moved from Top Gear to Star Trek Warp Drive Speed, and you seem to have opened a sub-office in the Newsnight and Today studio. Now, I think it's fair to say from the questions that we've received already that despite all this, a lot of people are still very unsure about what it is you actually do. So let's kick off with you describing a little bit of, demystify the black box of modeling, much as we got when we had David Halpin and Susan Michie to try and explain to us a little bit about behavioral science. So tell us a little bit about the dark art that you're practicing.
Okay, so it's wrong to think of mathematical models as just there's one model, but we use a whole range of different models, different tools for different things. But I guess the kind of common thing is that the models are kind of a mixture of assumptions and data analysis, and we usually try and fit those models to data, and then we might use them for projections. And then if we have certain types of models, which are sometimes called mechanistic models, which track the underlying mechanisms, what's going on in the disease state and how it spreads in the community, then we can use those to sort of answer a load of what ifs, like, so what if we do something different? What if we impose this social distance measure or that one? And what if we do it now versus do it in 3 weeks' time? And those are the sorts of things that, obviously are quite useful for, or can be quite useful in kind of guiding public health policy.
Okay, so again, let's start off with an easy one then. So you can never fully test the accuracy of your modeling because the action of modeling changes the things that you're modeling because people take decisions and behave differently. But give me an example of how should we put it, your greatest hit. Where do you think you've done pretty well?
So this is in an epidemic situation, I guess.
Well, let's talk about COVID, shall we? Let's get to
you want to talk about COVID?
Yeah, well, no, give me, doesn't matter. Give me an example of something that really worked. If it is COVID, all the better.
Well, I think, okay, if we take the COVID examples, I think the work that we did in the early part of the epidemic, so this was Nick Davis and others at the school, but Nick was really absolutely central to it all. And we were looking at the potential impact of different interventions. Neil Ferguson at Imperial was working in parallel, as were other groups around the country. And we had to try and make a guess about the impact of different interventions on people's contact behavior, because underlying these transmission dynamic models is people coming into contact with each other. That's what we're actually modeling. And so we have to kind of we had to make some assumptions about, okay, if we impose this particular intervention, non-pharmaceutical intervention or social distance measure, how might it impact on our behavior? And we really didn't know what the answer to that was, and we had to make some educated guesses about it. But in retrospect, our educated guesses weren't a million miles away from what actually happened. So I don't think we did a particularly poor job at sort of informing different policy interventions at that time. I think we did okay. And and as I say, others were working in parallel. So it wasn't just, policy isn't made but just looking at the results of one model. We do it here in the UK by looking at combinations of models and to see whether you're getting some sort of consensus about what might happen.
I think that is a very important point. It's never down to one person. It's never down to one group. And also, you said it was an educated guess, but again, to be fair, I mean, your own CV shows you've done quite a lot of stuff on behavioral science, as it were, giving data on what ordinary people do at works, at work, in the shops, etc. So you don't go completely blind into this.
No, that's why we collected those data, and we've collected them actually over the epidemic as well. So we were lucky in this country in that regards, is that in that we had collected these sorts of data about interactions in order to inform mathematical models. That's why we collected it. And so I think the models were quite well informed at the start, and then actually we've continued to collect those information through surveying panels of people every week since the lockdown in March. And so we have tracked how behaviour has changed over the course of this epidemic, which allows us to keep our models up to date, and also it's just straight interesting. And we know roughly how many contacts people are making, and we can get some inference about the impact of the different measures. So, if you impose social distance measures or take them away, how does that actually affect people's contact patterns?
You suddenly sound like a psychiatrist. You're just a voyeur underneath, aren't you? Wondering how people behave. Certainly.
Yeah.
Well, let's also keep slightly topical, because it just so happens this morning some folks in Edinburgh, computer scientists, have done a kind of remodel, as it were, using the same, I think, code and data that were available in March, but come up with a somewhat different conclusion as to what might have been the best course of action. And to be fair to them, they don't say this is what you should have done. They just said, in an alternative universe, had you done these things, it would have looked different.
Yes, life's always a lot easier when you're doing it in reverse. At the time, there was huge uncertainties, and we were working under great pressure to get results out very fast, and so we couldn't narrow down some of those uncertainties, and we just had to do the best job that we could at the time. We will have made mistakes, of course we did.
I mean, the headline today in the Telegraph and other papers is that closing the schools was a mistake, in the sense that it certainly helped suppress at the start, but may have led in the longer term to more deaths, particularly in the second wave, as we approach that. Do you think that's whereas I don't think there's any way you couldn't have done that, but do you think it's still fair academically? I know you haven't really had time to look at it, but
I've only had a quick look at through that paper this morning. So, and I think it depends. I think what they've assumed is you could only put shielding in place for quite a short period of time, and that essentially what they did was split the model by imposing social distance measures. Then you make two waves of an epidemic, which effectively draws out the epidemic to be much longer in duration. But if you only have if you only impose your shielding at a short period of time, then release it, then in the second wave without shielding, you're going to get more deaths. Well, nobody would do that, really. I mean, if there was a large second wave, I'm sure we would have to reimpose shielding. And so it's sort of a silly point to make.
It's a kind of one of those great what ifs, like if the Archduke had not been shot at Sarajevo. But
well, it's what if we did something very stupid? Would something bad happen? Yes.
All right. Fair enough. Okay, so we're going to have to be fairly brisk today, because you're leaving bang on the dot, because you're moving straight to Sage, and I'm sure everyone will be hoping that you leave your mic and screen running. So please do remember to do that for us, because we'll certainly get a great response then. But as you're not going to do that, we'll have to be reasonably brisk. I haven't got much space for many questions, but I do like this one because it's slightly tongue-in-cheek, from Kenneth Fung, and he says this: Asian countries seem to have better results in this pandemic. Is that because their modelers are better than ours?
Maybe. I think there's an argument that we overthought it at the beginning, and we were sort of looking at lots of different interventions. What if we did school closure and this and blah 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 and that and blah 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 and that, and we were working on answering all of those questions, and maybe we should have just gone into lockdown and not thought about it, and just taken action straight away. But we didn't. We were asked to answer all of those questions, and we did. And maybe that time would have been better spent just not thinking about it and going straight into lockdown. Unquestionably, in my mind, it was we went into lockdown later than everywhere else, or than many other places, and that is in relation to where our epidemic was. And that's unquestionably the primary reason why we had so many deaths, unfortunately, in such a high numbers of cases. And that's what I want to try and avoid now. Cases are going up, and so I think we need to take action rapidly, really.
We're going to come on to that.
To avoid making the same mistake.
Although, again, to be fair, the population had already made their own minds, hadn't they, before your advice was, and Neil and many others' advice was acted on, I think we'd already done 50% of a reduction in our behavioural interactions, hadn't we? So it had already happened.
Yeah, in that week between the sort of 16th and the 23rd of March, for
Yeah.
those of you in the UK who might remember it, there were changes. I mean, the government did Prime Minister made an announcement, I think, on the 16th, sort of trailing that these things were coming, and people started to change behaviour very rapidly, actually. But it's interesting because the week before, people really weren't. There's just the behavioural and attitudinal surveys that were going on. People really weren't taking it at all seriously the week before, and so it wasn't clear that people would change their behaviour in any way so rapidly and so deeply as they did. That really wasn't clear. That was probably our biggest uncertainty at the time, and you had to bring people along with you. The government had to bring people along with you, with them, as it were, with these measures, because they were dreadful measures. They are dreadful measures, and there was no guarantee that people would have agreed to adhere to them.
Well, and that's a discussion we've had in other quarters as well, that had you done it much earlier, when people still thought this was just a rerun of swine flu, they probably wouldn't have done it. So
no, exactly.
Yeah. Okay. Now, one more question that's been asked, Shay Shoram-Meekan, which is, he's also rather specific, but I want to generalize that. He says, does modelling suggest that the new rule of 6 and mask wearing are likely to have a measurable impact on transmission? I want to change that slightly. I would say that we know that shutting everything down works. So turning Oxford Street into a version of a spaghetti western with, bits of tumbleweed floating down definitely works. That's clear. Do you think there really is any good evidence that anything else really alters the dynamics of a pandemic?
So, yes, shutting down Oxford Streets of tumbleweed, the lockdown did work. We know that. That's the one that we have good evidence for. But I think what you need to think about is that that isn't one intervention. That's actually many, many, many different interventions that were all imposed at the same time. So we closed schools, universities were closed. Non-essential retail was closed. We enclosed the entire hospitality and leisure sector. We asked people to work from home we enforced that people work from home unless they were key workers. And so, all of those interventions all came in place all at once, and that turned the epidemic around. So what we've got to think about now, if we just take one of those interventions on their own, is it going to be sufficient to turn the epidemic around again? And the answer is almost certainly not, because all of those things together managed to reduce the reproduction number from something close to 3 down to something about 0.7. So all of those together only reduced the reproduction number to not much below 1. And so if we want to keep the reproduction number below 1, we're going to have quite a lot of measures in place, unfortunately.
I'll let you out of your box in 1 second, but you've not answered the question. All of those are social distancing measures. Other than social distancing measures, do you think anything else makes the difference?
There are other interventions, there's clinical interventions that have improved in terms of reducing, the risk of death that has
Sure.
improved.
Yeah.
And of course, those are still coming on stream. The other big one, of course, is the track and trace. I don't know if that's what you're getting at, but
no, I was actually getting. Do you think whether or not you had a view on face masks? Actually, that was in the question that the gentleman asked.
Face masks certainly probably have a role. I think if you think of all of this stack of interventions, that's probably quite a thin one. I don't think it does a huge amount, but it's pretty cost-free. It's pretty risk-free. So why not do it? I don't think it's going to play a huge role, but it will play some role, and it's not a big cost for any of us, so we should do it.
Okay, so now then, where do we go from here? You've not exactly been a ray of sunshine recently on Newsnight. I think it was last night, the Today program, etc. What does your crystal ball tell us now? Off you go.
Well, the epidemic is increasing, of course, and increasing quite widely. It is, of course, much more severe in the north, particularly the northwest, but it is increasing across the country now, everywhere. And so we have to take action unless we want to, and unless we're going to face really large numbers of hospitalizations in the quite near term, and then unfortunately large numbers of deaths. You know, that this is still a killer virus, and despite the improvements in treatment, you know, many people will die if we let the infection run its course. And so, you know, I think it's important that we all go back together and act together to try and keep this infection at bay. And that means imposing, unfortunately, these social distance measures again. You know, they have been tried locally, you know, in much of the north of England. I mean, there's and elsewhere in Scotland and so on. And so far, they haven't been very effective, those local interventions. I wouldn't like to say that they've done nothing. They probably have slowed the epidemic down a little bit, but not in any sort of perceptible level. So we've tried these local interventions, which I hate the term local lockdown because they're not a local lockdown. They're mostly things like, well, I mean, you know, having to book to go to the pub or whatever. You know, really, is that making a huge difference, you know, to the virus? I don't think so. So, you know, I think we do need to take these interventions much more seriously, and we'll have to put a package of interventions in place. And the quicker that we do that, the better. This is the problem, I think, as I tried to explain before in the first wave. We acted too late, and so we let the epidemic get higher and higher and higher, and then we had to put the brakes on, and we were putting the brakes on at, you know, when things were really you know, a high level, and then we had to put the brakes on for a very, very long time, very hard to bring it back down again. And I think if we put the brakes on earlier, we don't let the epidemic get out of hand, then maybe we can use less brakes, as it were, and which is good for the economy and good for everybody, and good for the epidemiology, in that we won't get as many cases and deaths. So I really want the government to take this and act decisively now, rather than wait and be bounced into acting decisively sometime later.
And this is your or others' famous circuit breaker.
That's one way. I think I wouldn't use them on their own, you know, but that's certainly one way to reduce the epidemic now and bring it back. So, I mean, the idea of the circuit breaker is, I mean, things are growing exponentially at the moment, and what you do is a short lockdown of, say, 2 weeks, and a proper lockdown again. You know, again, it has to be quite severe, and so then you replace the growing exponential, 2 weeks of it growing exponentially, with 2 weeks of it declining. And so the difference then in terms of numbers of cases that you get is really enormous in the short run. I mean, if you let the epidemic run to its conclusion, which we won't, then it wouldn't make any difference. You've just bought yourself a few weeks. But in the short run, you know, and I'm talking about in months, over a period of months, it would make a large difference to the numbers of cases that you get. And the time period now should be measured in months, because it is at least possible that we'll be vaccinating in the early new year. You know, that's still uncertain, but WHO have made that clear, that it is possible that will be the case. And so I think if we manage to get through the winter without huge numbers of cases, and we start vaccinating sometime in the early new year or in the spring, then we will have done a fantastic, well, you know, we will have done a good job. I think if we let the thing get out of hand now, and then we'll have to impose, then we'll have a lot of cases, and that unfortunately means a lot of deaths. And we have to impose measures, and I think we'll have a very difficult time over Christmas with the virus at high rates and so on, and maybe having to impose quite strict interventions to stop that. So I would rather we did that right now, and we took the pain now. And I know it's horrible, you know, and nobody wants it, but I would rather that we took the pain now. We bought ourselves a period of low incidence, and then maybe we'll have to do something later. But I think we should. I would put the circuit breakers in as fast as we can, and I would also impose longer term restrictions. We should be working from home. I am now today, and we should be. And we should be taking other measures to reduce our contacts over the winter. We have to keep these in place.
You use the phrase "take the pain now," and Richard Beale, I think, is an intensivist, and Mike Juddo, I don't know, both are asking the same question, which is basically about: do you ever model the pain? You model the death, you model the infection, but do you model the loss of jobs, the misery, the isolation, the loneliness? Can you, the cultural and social damage that these things are causing? You say we'll take the pain, but do you model that?
A little bit. So in the past I have. I haven't really for this epidemic. There are others that are working on looking at have models as well to look at. So ONS and others have been working on looking at the impact of different interventions on the indirect effect. So how many deaths you might get if hospitals are full from other causes and other things like that. So the impact that it has, the impact of working at home, might have on bad posture and bad backs and things like that. So they are working so they have a series of model looking at these sorts of things. So yes, that stuff does feed in. And then the sort of on the economic side, that's the sort of work that the Treasury modelers and others look at. Now, we don't do that. I have actually been involved in work like that in the past, but that sort of feeds in separately into government through sort of different streams. So SAGE and the work that we do doesn't look at the economic impact, but the model, but there are a separate bunch of modelers and models feeding into the government separately on those.
And someone else has just asked, but if we do the circuit breaker and still, by your own words on Sky a couple of nights ago, the off switch still stays pretty off, by the way, you will once again get the opposite of a surge of people going to hospital. We're only just trying to get people back into their cancer care, etc. And you'll go back to square one on that. And that again will have a significant impact, even on the hard outcomes you follow, like mortality.
Yes, so that's the primary reason for doing this is to stop the epidemic getting out of control in the next few weeks or months and overwhelming our health service, and the impact that would have, therefore, just on deaths from COVID, but also on deaths from other causes or illness from other causes, because our health service becomes overwhelmed with COVID cases. So, and we're not that far away from that. I hate to be so gloomy, but in the north of England now, we are not that far away from the health service being stretched, because even if we turn the epidemic around now, because infections that occur today won't go to hospital for another week or two, and so the infections, hospitalizations will still go up for another couple of weeks.
Your modelling should surely be different from what it was in March and April. I mean, in two ways. One, if we look at the graphs from Europe, the gap between the surge in infections and the surge in death and hospital admissions is much longer across Europe than it was then. And second, we've changed the health service. We've now got these nightingales ready to come out of their own lockdown, as it were, and get to work. It's a very different setup now. Should you not be changing some of your modelling to accept that the parameters have changed?
The parameters have changed. The epidemic is not growing anywhere near at the same speed that it was in March. So we were facing a doubling time in March of sort of 4 days or something, and now it's something. It's a bit hard to estimate exactly, but it's probably sort of 10 to 14 days, something like that. So it is growing much slower, and the reason for that is because we are still careful about. So our contacts are still much reduced, and they're far reduced from what they were in before the epidemic. So the epidemic is growing. So the reproduction number is much lower, and the mask wearing and the other social distance measures also helps. So altogether, the epidemic is growing much slower than it was. That's actually the primary difference. The rest of it is quite similar, quite honestly. We have got a bit better at treating severely ill patients. That's great news, but still, a very large fraction of people would still die who get COVID, particularly in high-risk groups and the elderly I'm talking about, of course.
Okay. Now, a couple of people have also mentioned, picking this up, I think, from some newspapers, that when this started, you were quite happy to use the H word, herd immunity, as it were, in the Daily Mail. It was the Daily Mail. A lot of people use it. And they themselves have said you've done a bit of a volte-face. You know, when you originally said this virus is all around the world and spreading, the only way the epidemic is going to come to an end is achieving herd immunity.
Correct.
There's no way out of that. There
is no way out of that. So that is how the epidemic finishes. So I think the reason why I said that back then, and I've kind of regretted it, but on one hand I've regretted it, but on the other hand I don't, because what I said then was correct then, and it's correct now. The reason why I said it was there was this sort of assumption if we just go into lockdown it would all be over and that would be the end of it, and so people were kind of either they didn't know what they were talking about, or they did and they were kind of pretending otherwise, because that would not be the end of it. With the epidemic at that time when I said that, which was sometime in the beginning of March, by that, or middle of March I think it was, over 100 countries around the world had already were reporting COVID cases. It was spreading everywhere. So we were not going to just be able to stamp the epidemic out. Right at the beginning of an outbreak like, and that's what happened with SARS. If there's a few cases, and that's what happened with Ebola in West Africa, you can stamp it out and stop the epidemic and stop it spreading from its original focus. Once it's everywhere, you can't. And that was what the situation was back in March, and it's still the same. There's no way that we can stamp this out globally everywhere so it just goes away. We're going to have to cope with it. And so the only other way that the epidemic stops is through herd immunity, and that is the case now. The thing is that there are kind of two ways to get to herd immunity. One is dreadful and causes lots of hospitalizations and deaths, and the other one is vaccination. And so, what we have, the strategy that we've been following since March, at least I hope we have, is to essentially slow the epidemic right down, stop it as much as we can, and wait for a vaccine to come. And that is still, I think, the strategy. I hope the strategy that we are following, and that is the way. And then through vaccination, eventually you will achieve herd immunity, and eventually you can come out of these measures and go back to something approaching normal life. But
fair enough.
That's what nothing has changed since then.
Now, my last question, you're about to go to say, so the last question is about that. Now, your colleague, Graham Medley, writing in the Times a couple of days ago, made a very good point, and I'm sure you'd agree with him, that these are wicked problems. Science shouldn't have the final say. SAGE isn't the only source of advice. And some of these decisions are as much social as they are scientific. And modelers like him, and I assume you, he said, we do not want to have to make those decisions ourselves. And I'm sure you would agree with that. But the last thing I'll put to you, though, is that, but in a way you do, though, don't you? You, Neil, and many others are quite strong in what you say. Neil just, on Life Scientific said, there's a temptation to be saying you really need to be doing this now, Prime Minister, or else. And that's a bit like holding a gun up to their heads, isn't it? Are you, where does just saying these are the facts, PM, to this is what you have to do, where does that line drawn?
Well, I don't think it's us holding the gun to the Prime Minister's head. I think it's the virus. And I'm just pointing out that the virus is holding a gun to his head. And I agree entirely with Graham. It is not our decision. It is their decision. It is a dreadful decision. These things, there's no way out of this where harm isn't done. And you're balancing harm to one sector of society in order to protect other sectors of society and so on. It's dreadful. I have huge sympathy for the politicians that have to weigh up these things and come to a decision. And yes, sometimes I sort of criticize them because if I feel that they're really not they're not realizing that the gun is pointing straight at their heads.
But I would say there are also other guns also pointing at their
There are,
heads,
yeah.
and it's a game. Yeah, okay.
But I think with some of these, they're not. I think shooting guns is probably not the right.
I use the analogy.
But I think
Yours.
some of these are not. Some of these actions can be both good for the economy and, comparatively good for the economy and good for the epidemiology. That's why I think early intervention is both good because you can then do it quickly, harshly, and start to ease it. And that is much better for the epidemiology, and I think may well be better for the economy as well. Late intervention, when things have got really out of hand, is bad for everything.
John, now, that was fabulous. We're going to let you go. I'd like everyone else to stay on for a couple of minutes. I have to say to John, though, what you've said has certainly not made me more cheerful, but I'm definitely much better informed. And as ever, you're never dull in anything you say, and it is absolutely fascinating. So if you want to go, you now go. Do please leave your mic and video on, as you promised you would. Now,
thank you.
Pleasure. Now, for the rest of you, do stay on for 1 minute, because we've got some rather exciting stuff coming up. Next Wednesday, in our longer format, we're having Andrew Lloyd Webber, and he will be talking about his new version of Evita, which, as you know, is how Eva Perón came to power in Argentina. And his new version, I believe, is set in Scotland and is called Nicola. And the new anthem, Don't Cry for Me, Pubs in Scotland. Also, Angela Merkel's Superstar and Phantom of the now completely deserted opera. But if that isn't enough, this time next week for the COVID seminar, same time on Thursday, we're welcoming Anders Wellenstein, not a name you may know, but you should. He's the Deputy State Epidemiologist in Sweden, Deputy to Anders Tegnell. And so he will be describing what they've done in Sweden. And the yin to his yang will be our own Gabriel Scally from the RSM on Independence Age. Ensuring that we don't repeat the Trump v. Biden show will be Victoria McDonald from Channel 4. And in the musical analogy, Gabriel will no doubt be portraying Sweden with songs from Stephen Sondheim's Follies, and Anders will see our own situation as Les Miserables. So if you want a musical 24 hours, Wednesday at 7, and then Thursday at 12:30. And as I say, all these come from the Royal Society of Medicine. We are feeling a little bit miserable ourselves at the moment when we look at our finances. So please, like everyone else in our situation, if you feel like becoming a big spender, do please spend a little bit of your money with us at the RSM on our website. So my thanks to you all, and my thanks particularly for John, who's now gone to save the nation. At least we hope so. And so same time next week, but don't forget Wednesday evening with Andrew Lloyd Webber. Good afternoon, everyone, and good luck.